I call this debate to order. Here's the gavel. All right, resolved, die on your own terms. For an opening speaker, we've already asked one person to kick us off, and that's Gary Holland. So Gary, could you unmute, and you have up to 4 minutes.
My timing, going to talk fast because I have a lot to say. Thank you so much. Medical aid in dying is a widely supported end-of-life option that provides dying people with peace of mind and comfort during a very difficult time. While only a small number of people will choose to use the option, to patients, it is a prime litmus test of person-directed care. It exemplifies a medical system that respects patients by allowing them to assert their values and priorities as death approaches. Furthermore, the evidence demonstrates that authorizing medical aid in dying protects patients, affords dying people autonomy and compassion during the most difficult time of their life, improves end-of-life care even for those who don't choose the option, and costs states almost nothing to implement. 3/4 of Americans, according to a 2020 Gallup poll, about 74%, support the option of medical aid in dying. Support is high across all demographic groups. Some other points include, and to be honest, most of these are Connecticut-centric. That's where I'm from, Connecticut, and so may not be true in all other states. The medical profession was against this for many years, but is now, for the most part, highly neutral. In Connecticut, for example, there are even several state legislators that are doctors and big supporters of this kind of legislation. The individual must be able to self-administer the medication. It can't be given by a physician, only prescribed. Physicians who comply with all aspects of the aid in dying law in Connecticut are given civil and criminal immunity. And let me be clear about that. That is proposed legislation. It does not exist today. The two main groups that are most often vocal against aid in dying in our experience is religious groups, especially the Catholic religion, and advocates for the disabled. I understand that many believe that dying is in the hands of God and humans should not take their lives. That is fine if this is your religious belief, but not everyone shares this belief. No one can be forced to take this route. An interesting sidebar, in Connecticut, 69% of Catholics surveyed support aid in dying. Some advocates for the disabled feel family members of a disabled person may believe they'd be better off if they died. Their fear is that the family may coerce the disabled person to take their life. But with all of the guardrails and requirements in place in a properly formed law, this would be extremely difficult to make happen. Life insurance payments cannot be denied to families of those who carefully follow the law's directives. A person must be an adult, age 21 or older. It has been the practice in Oregon for 25 years without, so far as I've been able to determine, a single instance of abuse or coercion being reported. This is not suicide. People who are in terminal medical condition want to live. They just understand that they are terminal and don't want to die in a way that is out of their control. Those who commit suicide want to die. This is an important distinction. Some people say hospice is sufficient, but they haven't heard the uncounted stories of spouses who saw even hospice's Herculean efforts aren't always enough to control the pain of many end-of-life conditions. 11 states have already supported legislation on the books: Oregon, Washington, Montana, Vermont, California, Colorado, Washington, D.C., Hawaii, New Jersey, Maine, and New Mexico. It's on the docket each year in many more states, as efforts to enact this kind of legislation are pretty universal. Sadly, just yesterday in a Connecticut State House Judiciary Committee review that has been proposed, it was narrowly spiked for what is now the 7th or perhaps the 8th year. It's unfortunate that this important personal freedom is not being given the opportunity to be aired in the full legislative body. But for sure, it will be back in the next legislative session. It's something whose time is well overdue. Thank you.
Thank you. And I don't know what I'm hearing there. Okay. To say thank you to our speaker, you can always use your hands here, and to appreciate that they spoke, and that especially Gary went first. So thank you. So I'll ask you to raise your Zoom hand if you have a question for the speaker. Normally I'll just take one or two, and normally the first couple of people I see. So if you have a question for the speaker, you can go ahead and raise your Zoom hand. All right. Vincent, would you like to ask a question? You can ask your question to me, Madam Chair.
Madam Chair, can we have a definition of what is a right? And can we also define on their own terms? What does that, what's the definition of someone's term? That might help. Thank you.
Sure. Gary, would you like to address that?
I'm not sure I can give you a legal definition. I think a practical definition is that on your own terms is really something that's defined by the individual. The individual needs to be able to decide what happens in their life. Individuals are able to map out what kind of medical treatments they get. And if they are not able to handle it directly, they're able to designate a surrogate to handle that communication process for them. And I apologize. The second point that you asked was?
Define what is, Madam Chair, I had asked for a definition of what is the person's right. Why is it a right?
Yeah. Yeah. What's your perspective on that, Gary?
Again, I believe it just has to do with a person's ability to control what happens to their person. They should be able to decide what happens to them, when it happens, how it happens. It should be their decision, as long as they are capable of making the decision.
Sorry.
Okay.
All right. And I'll take one more question from John Dykers. Would you like to unmute? Ask your question to me. Yeah, John, did you want to unmute? There you go.
There we go. I was late being able to get into the program, so excuse me if this question is not appropriate, but I wondered if the speaker addressed the difference between the fear of being dead and the fear of the process of dying.
Okay, Gary, do you want to address that?
I didn't address that, and I have to confess I don't feel competent to address that. That certainly is a complicated area. I do know that in properly formed legislation, the legislation outlines a multi-step process to make sure that the person has a clear understanding of what the process is going to be, and what their alternatives are, and making sure that they're able to make the decision between, do they want to continue the path that they're on, which the medical community has concluded is going to end up ultimately in their eventual death, and making sure they understand what the alternative is, the pathway to death, according to whatever condition they may have, which is terminal, and what the process would be if they decide to take an alternate route. And by the way, in Connecticut, again, I can only speak about the Connecticut law. In Connecticut, the person has to be declared by two separate doctors as being having a terminal condition that will be terminal if it goes through the normal progression within 6 months. This isn't something that you can do if you are just in a very long-term degenerative disease condition. This is only for people that have been determined to be in a terminal within the last 6 months of their life, if the condition, whatever it is, proceeds as would be expected.
Thank you. And with that, the speaker is thanked. I'm going to give other people the opportunity to speak and answer questions. So hands for our speaker. Now we have several people actually lined up to speak on the negative side, which thank you very much for responding to that. Whichever side you are on, go ahead and sign up with your whip. So our next speaker will be speaking in the negative, and that is Leah. So Leah, you have up to 4 minutes.
Thank you so much, Madam Chair. I used to be more sympathetic to the pitch for assisted suicide. I think what we all can agree on in this debate is that we often don't treat the dying well, and that we want better end of life care for everyone than we currently have in the United States. But what I think assisted suicide, which is actively seeking someone's death as opposed to prioritizing pain management over extending life, actively seeking someone's death changes our relationship with death, and it changes it for the worse, not only for the aged or the actively dying, but for anyone who is vulnerable and dependent on others who worry that they feel like a burden and that they have a responsibility to cease burdening others. When we talk about choosing death on your own terms, what we're talking about is making death an act of expressive individualism, a self-authored work, something that we control, something we feel a responsibility to script and carry out in an acceptable way. And what's happened in other countries, not yet in the US, is that once we start saying death is something chosen and something people can choose in an expressive way, it doesn't just stop with the actively dying. In Belgium, the Netherlands, and Canada, people have removed the restrictions that people be approaching death, be suffering from a terminal illness, because ultimately, once it was a question of autonomy, people said, who are we to decide which lives are worth living? If someone says they believe their life is not worth living, it's not fair for a doctor to decide against them. Canada, until very recently, was preparing to expand assisted suicide to minors who wanted to die and who were not terminally ill. Because once this was a question of individual choice and autonomy, they didn't have a way to articulate what the point of life was. Once we didn't have a way to articulate what it meant to have a life that was difficult, have a life that involved suffering, and find meaning in it anyway, whether or not you were actively dying. I think the alternative to seeing death as something we author, something chosen and controllable, is to say death is something hard that each of us will receive. Death is a lot like labor or birthing a child. It's something hard that you can plan for some contingencies of, but ultimately you respond to, rather than ultimately control or script. And in both cases, the more we tell people that total control is an option, that scripting is an option, the more we set them up for a really crushing disappointment when ultimately it's not. I know there are legal guardrails to prevent coercion or to try and limit it, but they can't prevent the soft coercion of fearing that you're disappointing the people around you by virtue of your need. In Oregon, in the most recent study of people who sought medically assisted dying, almost half of them said one of the reasons they wanted to die is that they worried they were burdening the people who loved them. More people said they were worried about being a burden than that they were worried about controlling their own pain. They worried more about the pain of others and saw that as the reason to die. When we make things chosen, it can feel like we're expanding people's options, but often once something becomes an active choice, it becomes harder to bear. For parents who receive a diagnosis of Down syndrome in utero, it often feels harder, as Sarah Zhang reported for The Atlantic, to decide what to do, because at that point, once they've been warned, they feel like everything hard in their child's life will become their fault for having chosen it. If their child experienced a disability after birth, the parents wouldn't feel like they'd picked it for them. But the warning meant that they felt like every moment of suffering was suddenly opted into by the parents. And assisted suicide creates a similar burden where the very people who love someone who's going through something very hard suddenly are faced day by day with the question of, do you think maybe the loving thing to do is to kill them or to support them in the choice to be dead? And that means every hard moment, every bedpan changed, every wound dressed is a question of, are you actively choosing for them to live like this once death is on the table? It's hard to imagine that doesn't change the way we think of dying. And I just leave everyone with this image. Think about a nursing home where many people are going through different struggles, but kind of similar disabilities, where you see your friends one by one choosing death. You might think your life is worth living when you first got your diagnosis, but as you see other people make the opposite choice, it erodes your own sense of yourself and whether it's reasonable to live in the face of a terminal diagnosis or a severe disability. We need examples of valuing the people who are burdensome, not of seeing their difficulties and then trying to get rid of them because we're afraid we can't bear what they need from us.
Hands for our speaker. I'll take a couple of questions. I see your hand, John Chessiter. Would you like to unmute, ask your question to me? All right. While you are working on that, I'm going to move to Gretchen, but then I'll come back to you, John. So unmute when you can. Gretchen, would you like to ask a question?
Yes, Madam Speaker, though I'm not sure I have it well formed. I'm sorry, Madam Chair. I think the previous speaker discounted as not value adding the sense of burden and discomfort that a person feels when they're approaching their death. I believe the first speaker made clear that only the person dying can make this choice. So my question is to this speaker is, why are these things you saying shouldn't matter? Why shouldn't those matter?
I think it does matter that we burden each other, but that's the shape that love takes. And the more we kind of see both strong burdens as somehow illegitimate or an imposition on the people we love, the harder it is to rely on each other, even in small ways. We set a norm that being a burden is dishonorable, disgusting. Richard Hanania, who's a political writer, said that he thinks more people should consider assisted suicide because he thinks it's the last act of love that parents can show for their children. That the responsibility, and he frames it as a responsibility of a parent, is to set their child free from as many burdens as they can, financially, education. And the last burden is, I don't want you to be burdened by my death. I'll kill myself if I have to, so that nothing about my life inconveniences you. That's not a filial relationship or a relationship of love. That's a relationship of strangers, where the idea that my need would disgust you or be wrong to share with you, again, it's just not a familial relationship.
Thank you. I'll take one more question. John, were you able to unmute there? John Tressiter? There you go.
Yes.
You can go ahead and ask your question to me, Madam Chair.
Okay, Madam Chair, I was wondering if the speaker thinks about what about the terminally ill or people who or have an inoperable form of cancer?
Yeah, I think the priority should always be on making someone comfortable rather than seeking their death. And I know the lines can feel a little blurry, where you'll have moments where a doctor might say, we can up your morphine, but that's going to put you at greater risk of dying. But I think there's actually always a pretty clear line between we're doing this for the sake of the person's comfort and we're doing this in order that they die. And one way you can think about it is, are you disappointed if they don't die, right? If they're comfortable but not dying, do you feel like the treatment has failed, not dying faster? And that creates kind of a sharper line between those two things. I really love the work of Atul Gawande in Being Mortal on the range of what it can look like to serve and care for the dying, with just the focus on helping them die comfortably and surrounded by people they love, rather than saying that their dying is controllable or perfectible, saying what will be comfortable, how do we show people they're loved? And even more than that, how do we show them that the fact that they are dying does not diminish their worth or their lovability?
All right, that's two questions. So I'm going to say hands for our speaker. The speaker is thanked. We'll move to our next speaker in the affirmative. And I see Lee Amon. Did I pronounce that right? Lee?
Hi,
Hi. Yeah, you have up to 4 minutes. Go ahead.
thank you.
Can
I
you
would
move
like
your
to.
camera so we can see you a little better?
Can you see me
Yay,
now?
there you are.
Okay.
Yeah.
I would like to share the experience of my family, and specifically of my mother, who died via a medical aid in dying procedure exactly 1 month ago today. Right up to the time that my mom passed, her mind was clear. She was alert. She was sharp. Her sense of humor was intact. She understood everything that was going on, but her body had completely worn out. At the age of 98, my mother was suffering from an advanced cancer in her digestive tract, probably pancreatic. We never actually were completely sure exactly what it was, but we know it involved the pancreas and liver. She was in extreme pain. And when my mother said she was in extreme pain, she was in extreme pain. Okay, even with hospice care, even loaded up with morphine, she was in extreme pain. Okay, at the same time, she'd been suffering from macular degeneration for many years. I took her every 10 weeks to get a shot in her eye. We managed to salvage some sight in one eye, but the other eye was deaf, was completely done. She was also almost completely deaf. So there she was. Her mind was as active as anybody's. And at the same time, she couldn't move, she couldn't hear, she couldn't see. Would any of you really want to live under those conditions? My mom did not. She not only requested the medical aid in dying, we're here in California where it's legal, she demanded it, and she was really impatient about it. She had to talk. She talked to 3 different doctors. At least 2 of the sessions had to be a minimum of 48 hours apart. And she had to put her request into writing, witnessed by 2 people, one of whom could not be a relative or in any other way would benefit from her death. The doctor came with the medicine, mixed it into 3 ounces of apple juice, which my mom drank through a straw. She had to personally be able to drink the medicine herself under her own will. She was surrounded when she died by her children and grandchildren. We held her hand. My daughter sang to her. I can't think of a better way to pass away than that. I compare that with what my father went through at his end of life, where he was suffering from brain cancer, and they kept treating him long after they knew that he only had weeks to live. One of his last words to me were, "I've lost everything. I have no dignity left." None of us wanted for that for Mom, and Mom certainly didn't want it for herself. I suggest that anybody who is opposed to this sit with somebody who is in that dying situation, who is in extreme pain, no matter how morphined up they are, and I suggest that would change your mind. Thank you very much. Yeah, I'm done, even if I have more time left.
Madam Chair, you're muted.
Yeah, I just noticed that. Thanks. Don, do you have a question for our speaker? You can ask it to me.
Yes, thank you, Madam Chair. I'm very sympathetic with both positions here, and I have a question. I wonder if we were to expand the aperture a little bit of this conversation, and ask the question, if I may, in my own situation, my mother was diagnosed with breast cancer, and this was many, many years ago. And they told her that she could take chemotherapy and radiation therapy, which is very rudimentary at the time, and that it would give her another 5 years, or she would not take any of it and she would possibly die within a year. And I was wondering, if, Madam Speaker, if the speaker would address the question of whether someone should be able to have the option in that situation to refuse care in order to live as fully as they can for the time period that they have. I was wondering if the speaker could address that.
Yeah, Lee, would you like to briefly address that?
Well, I don't claim to be an expert of any kind. I can only share the experience of what my family went through. What I can say is that you can refuse care today. Nobody can force you to get medical care of any kind. So if you are faced with a cancer of some kind, you can choose to not get radiation treatment today. It's no different. So I'm not sure exactly what your question is.
All right.
Well, Madam, if I can clarify,
Okay, Don.
my question is not so much a question of legality as it is to address the question on the table, which is dying on your own terms.
I can tell you for a fact that at the age of 98, in the condition she was in, my mother did not want any further treatment, and that was the right decision for her. Now, if I was faced with those same things today at the age of 65, with two 20-year-old kids, I would probably make a different choice for myself, and I would probably try to extend my life to the degree that I could. But if I was in my 90s, probably not.
Thank you, Lee. I want to give hands for our speaker, and with that, the speaker is thanked. I'm going to go to a speech in the negative. Tom Cook. Tom, would you like to speak? You can unmute, and you have up to 4 minutes. I'm looking for Tom Cook. Otherwise, we will go on to someone else and come back to you.
I'm right here.
There you are. Yeah. Well, would you like to speak? You have up to 4 minutes.
Sure. Yeah, I just want to speak. I understand the perspective from the other side of the argument. I've had had a mother who was in the hospital on life support and had to make the decision for that to be taken away and for her to pass away. I also have a son with special needs, and I wish I had more time to study this topic before this debate. I didn't, and I'm not sure what the length of the history is in California with assisted dying, but we have seen in other countries which may have had it longer, where the initial idea was a good idea for those that were terminally ill, that were making the choice themselves. And the guardrails, as the first speaker again on the negative talked about this, which she did an incredible job of laying it all out. The guardrails can easily be taken away little by little as this becomes more acceptable. And you have situations that have been reported in other countries where people that are financially destitute have chosen to end their life because it's an option. And I just, as a parent, I have a child with Down syndrome and autism. Eventually I'm going to die and they're going to be left alone. And my wife and I will die and he will be left by himself. He's nonverbal, so he can't advocate for himself. And I would be afraid to leave my child in the hands of legislatures of the state and federal if this starts to expand and take foothold in this country, what framework it would be in by the time I died, where someone could just help him to agree to end his life because he's a burden to the society. And that's something that we can't fathom at this point. But as I said, we've already got people choosing to die who are not terminally ill, that are destitute, financially broken or whatever. And that is where this can lead, unfortunately, when you open it up. And I'm not sure how we can trust humanity to keep the guardrails in place.
Okay, thank you for that. Hands for our speaker. And I'll take a couple of questions. Taylor Johnson, would you like to unmute and ask your question to me?
Yes, Madam Chair. My question is, if the guardrails are not put in place, if legislation does come out for assisted suicide, would the speaker feel that something would need to be brought up to the Supreme Court, or something needs to be brought up to each individual state to make sure the guardrails are put up in particular?
Okay, Tom, your thoughts?
Yeah, honestly, ma'am, I don't trust the system that we have in place. Our judicial system is flawed as it is. And my son couldn't speak for himself. You know, I'm just looking into the future of where this gets to be a common thing in all states. And we start to purge society of those that want to die, that are a burden. They think they're a burden and they want to die. And I just cannot see a court system, a legislative body being a backdrop, especially as faith in God is diminishing in society. There are people with no moral guardrails. It then becomes the law of the moment.
Okay, I'll take one more question for this speaker. Grace, would you like to unmute and ask your question?
Madam Chair, I wonder if the speaker would address like where the guardrails he thinks they should be exactly. Like, should there be absolutely no availability of assisted dying? Would he support the current laws in California or such that require that a person is able to speak for themselves and take the drug themselves? Or would he support some expansion of that, for example, with people who have severe dementia or something like that?
Okay, Tom?
Yeah, I think the first speaker, I guess in the negative is what we call them, the lady, I forgot her name. She clearly knows what she's talking about and has researched this, and she laid it out. The guardrails, it doesn't matter if they're in place. They can be taken away. And when you open this door, you've opened it. And you could say California's done a great job with it. Oregon's done a great job with it so far. But I've seen the transformation in other countries of just reports. These are news reports of people being allowed, they're taking it another step where you're allowed to die without having a terminal illness. And that is tragic. That is not how our society needs to be. Thank you.
Thank you. Hands for our speaker. With that, the speaker is thanked. I see hands for questions, but we're going to move to another speaker, and you might want to sign up to make a speech or get your question in later. So our next speaker in the affirmative, I have Corey Carroll. Corey, would you like to unmute? And you have up to 4 minutes.
Thank you, Madam Chair. And just to give you my background, I am a family physician. I practice in Colorado. I have helped about 17 patients with medical aid in dying. I'm also one of the national medical directors for Compassion and Choices, so obviously I have a bias. But let me start with kind of the talks. Semantics, the terms suicide. Gary, I think, made it very clear. Patients who have been told by people like me, doctors, typically oncologists, cardiologists, pulmonologists, you have a disease and you're going to die from it. That's different than the individual that says, I had an event in my life and I'm not feeling well and I don't want to live anymore. So, and it's the same argument of murder. If I shoot somebody with a gun, I am a murderer. But if a soldier shoots an enemy individual with a gun and kills them, they are not a murderer. What's the difference? It's the semantics, it's how this all plays out. So understand that this is not people wanting to die, these are people wanting to live.
Second, advances in healthcare are amazing. The first negative speaker, Lee, said, well, what about birth? And well, great. My father's mother died in childbirth in 1914 because there was no C-sections. Well, now we have C-section. We have antibiotics. We have stents for the cardiologist to put in the arteries. We have chemotherapy. We have amazing treatment to help people not die. The trouble is you're still going to die. And what are you going to die from? And what is it going to be like at the end of your life? Third, my experience. I've been at the bedside for all the patients I've helped. I've also been in the hospital, and I've been on somebody's chest compressing them as they're dying. This is incredible. As I think Lee pointed out, my experience, they have their family members sitting by the bedside. They're holding their hands, they're singing to them. They're telling them how much they love them. This is not a suicide terrible event. This is how you treat people you love, how you give people you love the ability to take control. And the argument of, oh, I can control your pain, yes, but maybe they don't. As Lee pointed out, his mother wanted to communicate, wanted to be clear of mind. You can't do that on high doses of morphine. Yeah, American with Disability Act, I understand the last speaker's concern. There's no evidence that this is taking people's lives. All the laws in the United States of America require mental capacity. You have to bake so you be. And yes, can there be a possible situation? Let me tell you something. If you're going to want to snuff out grandma because you want the inheritance, you're not going to use medical aid in dying. So I get the concern, but this is speculation. The record and the data shows that this is done with love and compassion. People are having a beautiful end of life the way they want to have it, and no evidence of any abuse. Thank you.
Thank you. Hands for our speaker. I'll take a couple of questions. Bill Carter, you want to unmute, ask your question to me.
Yes, thank you, Madam Chair. I'm interested to hear the speaker's view from being someone in the medical profession about the realities and limitations of even the most aggressive forms of hospice care. From my readings, not every element of physical or psychological suffering is treatable. So the argument that we should use all medical technologies to ease suffering and let dying takes its course. Sometimes that doesn't even work. So I'd like to hear the science about the realities of hospice care.
I'll do my best. Thank you, Bill, Madam Chair. There are, and again, when you define suffering, it's not necessarily pain. It can be the loss of a physical activity. It can be the inability to toilet yourself. And again, some people say, well, that doesn't matter, but to me, it's not my job to tell people what's important, what's not important. I don't think there's scientific evidence about this topic, but there's certainly if you talk to any hospice palliative care doctor, they will verify that there are some patients that suffer and that cannot be controlled with medical care. The last thing I'll say is all of the data in the various states, which cumulative have over about 100 years, if you look at each state, about 35% of the patients prescribed medical aid dying that qualify don't end up taking it because they don't need it, because they were afraid, they were worried, and it did not move to that, and they died through the hospice palliative care naturally. So that's another piece, it's peace of mind.
Okay, I'll take one more question for this speaker. Leah?
Thank you so much, Madam Chair. I appreciate the gentleman talking through why he supports medical aid in dying for people who are actively terminal. I want to ask him how he'd extend his comments to cover Canada's regime, which does not require that people seeking aid in dying be diagnosed with a terminal disease, which would extend it even to people who have treatment-resistant depression. Does he think there does need to be a guardrail that people be actively dying or expected to die soon? Or does he think anyone who feels their suffering is incompatible with a good life should be able to receive aid in dying?
Thank you, Madam Chair, and thank you, Leon. I appreciate that difficult concept. I don't think America is Canada, nor will it ever be. Number one. Number two, a lot of the concerns that I have as a physician, patients coming to me that I have early diagnosed them with dementia, and they have, quote, a terminal illness, but not 6 months to live, but they know what's going to happen to them. So in the Colorado law, in the laws in the United States of America, without a 6-month prognosis, you cannot access the medication legally. Canada, that's different. And honestly, that's, you know, my view of life is I've watched my mom die through Alzheimer's dementia, and it was terrible. Watching the last year of her life where she couldn't even communicate, she was incontinent, she had bed sores, but she was a Catholic, and she would never have chose this for herself. And that's the point. It's people choosing it for themselves, not me making a decision, not me saying you're not worth it. I think I've had examples where patients have asked for medical aid, died, and said, wait, let's get my oncology colleagues involved. Let's see what we can do to help you. But there are times where you can't prevent that. So I think in America, I can't imagine a time where we will see as Canada, Brussels, Belgium, Colombia, Luxembourg, Netherlands, New Zealand, Spain, and all 6 states of Australia offer this option. So that's the best I can do for you.
All right, so that's 2 questions. So I'm going to say thank you to our speaker. That the speaker is thanked. Okay. Also, Dr. Carroll was a really great contributor to the Colorado debate last week. Props to you. Thank you so much. We're going to go to a speech in the negative now. I'd like to call on Paul Norris. Paul, you have up to 4 minutes.
Yeah, and a bunch of really tough acts to follow also. I don't know, this is more like musings, I think, than a coherent speech. And I'm not opposed to all assisted suicide, but again, our resolution says die on your own terms. So I think I can make a case against that. There was a book that really stuck in my mind. I think it was Old Man's War by John Scalzi. And it had this deal where when people got really old and their bodies hurt, they would get a brand new body, but they had to be willing to go to war and fight aliens. And for some reason that stuck in my mind, you know, because it really brought out just how the aches and the pains kind of add up and they can affect your will to live. Or I remember an uncle of mine, you know, when he was getting up there and he said, you know, most of the people I know are dead. And somehow, you know, I remembered that and how different life must feel or can feel for a lot of people. So, and I've read that dying in agony is no longer common, but I've been convinced by prior speakers that maybe what I read was not true. I will say, from my own experience as a psychotherapist and my own life, actually, you know, life can seem not worth living for a period of time and then can actually become very fulfilling. So, you know, I would just kind of add that to the mix and, you know, distinguish, you know, fatal disease from just mental depression. And again, you know, I'm looking at how strongly we have worded this. I'm also aware, you know, of times, you know, choosing to die can be beautiful. Someone I knew made that choice not so long ago, you know, by a lake, took Seconal. I think this was in Washington or Oregon, with his wife and his son there. And, you know, but he knew he only had about, you know, 2 weeks or so to live anyway with fatal cancer. So choosing to die can be beautiful. But then again, I look at human nature and based on everything I know from history, if you can imagine something going wrong with human nature, it will. Especially when there are power or financial incentives. And there can be enormous financial incentives around this. So I guess the last thing I would say is, you know, I mean, let's face the fact, you know, there's no way you can stop somebody from dying on their own terms who is really serious about it and, you know, has any of their physical capabilities left. But I think as a society, I don't think we want to encourage this. So that is my somewhat wishy-washy speech following the strong speeches that have preceded me, and now open to taking questions.
Okay, thank you very much, Paul. Lisa, you have a question? You can unmute, ask to me.
Yes, Madam Chair, thank you. Just a brief question to the speaker, this just past speaker. We talked, or also one of the other speakers who spoke about guardrails, who first brought up the part about guardrails. How do we keep the guardrails for people to protect them? But what I'd like to know is to protect them from being influenced to go toward the direction of death, of choosing death. My question is, what about guardrails in the other direction? Does anyone have a thought about guardrails for people for whom this is very needed and necessary? And if it is not allowed, and it has nothing to do with life not being worth living, it has to do with what that person has capably decided for their own reason, and they are terminal and they have not been pushed. In fact, let's say in my case, it was I who tried to convince my husband, who had ALS and was dying, maybe that he could hang on a little longer. So my question is, what about guardrails for someone like him, so that he is not forced to go on in a situation in which he was in pain constantly, could not do anything for himself, and was more afraid of being in a frozen state. I think most people know what that means, where everybody would be making decisions for him, and he wouldn't be able to move, but he'd know what was going on, versus death. He preferred death, and he was very afraid of getting to the point where he'd be in that type of frozen state. So what would be guardrails for him is my question.
Lisa, I'm so sorry about your husband.
Thank you. Thank you.
Paul, would you like to speak to that?
Well, I think the only thing I can say is I'm totally sympathetic, to what you are saying. And, being 75, about to knock on the door of 76 myself, I would certainly choose, I would want to die rather than go through an experience like that. So I don't know, how to turn that into an answer about guardrails. It's an interesting idea though. So guardrails against, let us say, excessive pain or suffering. That's an interesting idea, and I think it's totally flipping everything around, and glad you brought that up.
Yeah, perhaps in future speeches that might also get addressed, because that is important. Thank you, Lisa. How about one more question for Paul? John Dykers, do you have a question for Paul?
To share an experience as a physician. First of all, ma'am, I'm sorry about your husband, because I had a patient. I practiced family medicine for 46 years and have been retired for 13. But I had a patient who had ALS, and she was getting progressively less able to do. And bless her heart, she took a .22 rifle and tried to shoot herself, because she couldn't get anybody to promise to help her die when she was really so disabled that she wanted to die. She didn't want to die yet. She was doing fairly well, but she hastened it by shooting herself and added an injury to her already difficult medical situation. And I wanted to share with my fellow physician, family physician over. I'm sorry, Doc, I didn't catch your name. But I had an end of life plan that I shared with patients when they were well and healthy and doing their annual physical, not when they were on the brink of death. Let's talk about this now. What do you want to be able to say to people when you can't speak for yourself? And this plan was universally accepted by patients. And it goes like this: if you can fix me, please do. If you can't fix me, please help me avoid pain, fear, air hunger, nausea, thirst, and the loss of my dignity. I understand that it may take a couple of days to figure out whether you can fix me or not. I also understand that morphine may be more effective at relieving my air hunger than oxygen without prolonging the process of dying. I think I may have left that important phrase out when I was listing the things they asked to do. And one of them was avoid nausea, thirst, etc., and prolonging the dying process.
Thank you very much for sharing that, John. Paul, did you want to respond to that before we move on?
Well, just one a really great point that I think came out of that. I mean, you know, thank you for what was actually a speech, but it was a very good speech. So, but just you know, unsuccessful suicide. And I realize I did say you can't stop somebody who is really motivated and mobile from ending their own life on their own terms. But actually, you know, the truth is a lot of time when people attempt suicide, what they manage to do is just give themselves yet another wound to carry. So that is a really excellent point that I don't think has come up in this debate before.
All right, hands for our speaker. With that, the speaker is thanked. All right, we're going to move to a speech in the affirmative, and in the interest of transparency, I'm going to tell you who's on our list to speak so that you know kind of where you're at. So in the affirmative, I have Marcia, Lisa, Robin, Leslie, Sally, Craig, and Belinda. And to speak in the negative, I have April. So we are leaning toward the affirmative, and I'm going to call on Marcia now. Marcia, you can unmute and you have up to 4 minutes.
Okay, thank you, Madam Chair. I would like to pick up on a couple of points that came up earlier. The first speaker in the negative talked about people having the fear of being a burden. What we know from the research actually is that the biggest, the most important thing people express, the majority of people who want to pursue an assisted death say what they fear is not so much pain as the loss of autonomy and the loss of their dignity. A couple of people have mentioned dementia and progressive conditions, and I'd like to tell you the story of my husband, who was a psychologist, a brilliant guy, and had a very early dementia. A neurologist probably would have said, "You're so early in this process, you have a long time." I can tell you that from my husband's experience and watching him struggle, if that was early, he didn't really want to see medium or severe. We live in California, where assisted dying has been legalized since 2016. But of course, with dementia, by the time a person is anywhere near the 6-month point, you know, of being within 6 months of death, they are not able to choose to die. They're probably not able to choose what they want to have for breakfast. You know, they're pretty much not any semblance of what they were as a person. So as a family, this was, of course, earlier in the pandemic, we started having Zooms with our kids. One kid is in Portland, one kid is in Los Angeles, we're in Oakland. And as a family, we talked about, okay, what can we do? Because my husband did not want to let the process run its course. He had seen his mother die very regressed in an institution of dementia. And there was no way he was going to follow that path. You may know that in the US, the only legal way a person with a dementia or a progressive neurological condition can end their life is by using what's called VSED, voluntary stopping of eating and drinking. In a healthy person, this can take a number of weeks. And we did not want my husband to go through it. I did not want to watch that process. And so what we did was we went to Switzerland, where he had, I must say, if you can call a death wonderful, it was. He was surrounded by his family. I was there, my 2 kids and their partners. We played music. He died quickly, painlessly, and peacefully with an IV infusion that he administered. So this is something that is missing from even the states that do have assisted dying. And by the way, those of us that are advocates for this never use the word suicide because it is so different from suicide. Suicide is generally an impulsive action. People that want assisted death, as someone said earlier, these are people that want to live, but they have a condition that will eventually end their lives one way or the other. And we certainly know with dementia or a condition like ALS or Parkinson's, it's a one-way street. You're not going to get better from it. So there are some, I'm part of a group in California that's actually advocating for an expansion of the current law because we think the 6-month limit is arbitrary and that people with progressive neurological conditions and dementias who are early enough in the process that they are competent to make a decision of that magnitude should have the right to have an assisted death. And my husband would have loved to die at home, but it wasn't possible. We think it should be possible for people in the US.
Okay. Thank you, Marcia. Sorry for what you went through. Will you take a couple of questions, maybe? Bill Carter, would you like to unmute, ask your question?
Thank you, Madam Chair. There was an issue that kind of came up in Marcia's talk, or the speaker's talk, sorry, that I would like her to expand on, and I'll frame it in this, another semantic issue here. From her experience, how would she distinguish between what we would call life and what we would call biological existence? And how does that semantic difference play into, the title of this conversation about choosing control over one's life?
Okay, would you like to address that, Marcia?
Sure. What I might rephrase your question as, what is the difference between meaningful life and biological existence? Clearly, a person with advanced dementia biologically is existing. The question is, are they able to have a meaningful life? And, we're never in somebody else's shoes, but I think this whole issue and the title of this debate about dying on your own terms really comes down to the question of whether we should have the right to exercise autonomy over our own bodies, over our own lives. And we do know, and the previous speaker mentioned it, we do know that people with conditions like dementia, with neurological conditions, are often in desperation taking matters into their own hands and dying, either injuring themselves or dying in very sad ways that could be prevented if the laws were more humane.
Okay, thanks. One more question. Linda, you can unmute.
Thank you, Madam Chair. First off, I want to extend to Mrs. Hoffer, Marcia Hoffer, my condolences on you. I just lost a friend 3 weeks ago that did starve himself to death because he was unable. He made a botched suicide attempt, survived it. He decided to take that route. He was suffering from Lewy body dementia, which is a horrible type of dementia. Robin Williams suffered from it and killed himself. Suicide rate is very high among those people. He was taken to an ER and revived, but he spent the next 2 weeks dying of starvation as we took care of him at home with some assistance from hospice. And I can tell you, I wouldn't wish that on anybody. It was the kind of experience that I'm glad you were able to avoid with your husband.
Okay, Marcia, did you want to respond to that?
Yes, thank you. By the way, the probable diagnosis that my husband had was very early Lewy body dementia, and there was no way he wanted to, go further in that disease. I will say that for a person with dementia, and this is something important to think about, for a person with dementia who, say, wants to die in Switzerland, where it is now the only country where a non-citizen can receive an assisted death, it's a tough decision because the person has to do it pretty early in the disease so as not to miss the window of opportunity, because in Switzerland, the person must be mentally competent, otherwise they won't allow it. So it's a very courageous decision. I told my husband, think of himself as a trendsetter, but he was determined enough that it was worth it to him to give up some good time for the knowledge that he would not have to go through what he knew lay ahead.
All right. Hands for speaker. That the speaker is thanked. I appreciate the tender and important things that are being shared. We'll have a speech in the negative from April Lawson. April, you have up to 4 minutes.
Thank you, Madam Chair. I have partially lost my voice, so I apologize. Madam Chair, if you would just tell me if you can't hear me, that would be great.
We hear you just fine.
Hear me, good. Oh, well, the first thing is I just want to acknowledge the things that are being said here. There are no more serious topics than this kind of thing, and the thing is that, like, it's going to affect all of us, right? Like, nobody gets to avoid this kind of question. And it's one of those debates where pretty much everybody has a personal perspective on this, whether it's you or your spouse or your parents or your grandparents. And I guess I want to sort of just reflect a couple of things. The first is that there are two words that keep coming up, dignity and autonomy. And I really could speak on either side of this topic because I think there are important things to say on both sides. And I really don't know what I think I think that there are stories where it's obvious to me that, like, the right answer is for, assisted death to be possible. And then there are stories where it's obvious that that's very dangerous. And the complexity is that as we, like, it's not that this is anybody doing anything wrong, but we're hearing the stories where it definitely should be possible on one side and the stories where it definitely shouldn't be possible on the other side. And I think part of the problem is that we only get to have one set of laws and we only get to have one society. And so I want to think about dignity and autonomy with you for a second. I think that one of the challenges with our kind of society, that my dad went through major heart surgery 2 weeks ago. And so we went through all these conversations about, he wanted to sign a DNR. My mom didn't want him to sign a DNR. What did the DNR say? What didn't it say? And one of the best pieces of it, he came through it and is doing well, thank God. But one of the things that one of the best pieces of advice I got was have a conversation with him about what dying with dignity would mean to him. And I think the problem is that it because of the kind of individualistic, really, like, I come from the plains, the like rugged individualist frontier thing our country has going. We have trouble understanding how dignity can exist without autonomy, and when we are really vulnerable. And I can say that that's been true in my own life, that like when I've been at my most vulnerable and like messy, I don't feel dignified. And like, I just think that there's something scary to me about what happens if we, in a society where you define dignity as having autonomy, not as having a lot of need, and then you give people the chance to not be a burden on other people. I don't know. I don't know what happens there. So I'm really interested in exploring questions of what if somebody doesn't have a terminal diagnosis, or has a long one, and what if it's not as simple as they are, real clear on their choices and they feel like in their right mind and are totally able to make the decision. Because I think often it's messier than that. I think often they don't feel good. They don't feel like they're worth much anymore. I think older people often struggle with how to understand their value to society, particularly if they don't have, grandchildren or whatever. And they're often depressed when they get news like this. And then that's a mental state from which I can imagine it being so easy to say, I don't want to be a burden. I'm just going to go. And I don't like that society. I don't like that picture. I don't want to live in that. And so I think I'm probably about out of time, so I'll wrap up in a second, but I just want to use my speech more as a question than anything else. I'll take questions, but how can we not have that outcome? How can we help people feel okay with need, okay with being old and unable to take care of themselves, knowing that they still have value, with this kind of way of thinking and talking about it?
Thank you, April. I'm glad your dad's doing okay. We've been praying for him. Sandy, do you have a question?
Yes, thank you, Madam Chair. In regard to several of these different speakers, I have one fundamental question. It's a big picture question. Who has agency over a life? Who has the right to determine whether a person should continue their life or let it go?
Is that something you would like to address, April?
Yes.
Okay, go ahead.
I would love to, thank you, because this is exactly where I think this gets tricky. I know that people don't like the word suicide coming into this conversation, but a thing I am very opposed to is a right to suicide. And so if we say at any time in life, and so if we say, where else could we reasonably say that right exists, right? But people live in networks, right? No man is an island. We have families. We have people who depend on us. Whether or not we think we're worth their time, they need us. And so I think this is, I'm not comfortable with saying, well, nobody else has that right, therefore I do, because that makes it too easy.
All right. We'll do one more question for this speaker. Al Smith.
Yes, Madam Speaker, I'd just like to ask or mention a few things to April and ask her what she feels about this. I think she understands that we all have a right to suicide. We can all get a gun and blow our brains out, or drive a car into an abutment, or jump off a bridge. We have that right. There's no law says you can, because you can do it tomorrow. And the other thing is, I've heard a lot of comments today about people who are just depressed and whatever. This has to be a terminal situation. A doctor's not going to approve taking of the medicine, prescribing the medicine, just because you're depressed. It has to be a terminal disease. And I'm very involved with this, like with Corey. I'm very involved with an advocate in Connecticut with compassion choice. And
what's your question?
Well, the question is, I'm curious from the two comments that I made, does April agree with that? Does
Okay.
she understand what it has to be terminal?
Yeah, yeah. April, you want to respond?
Yeah, thank you. So there are sort of two pieces there. The first is, I think we all have the capacity for suicide. I don't think that makes it a right. I think that the fact that we all have the capacity for all kinds of things we don't have a right to do. A right suggests to me that there's a moral claim that cannot be taken away from us. And I don't think that the ability to commit suicide, I mean, I think that, you know, hopefully most of us have not been in this situation, but sometimes we are in situations where we need to stop somebody else from doing that. And I think we all would, in most things that we would associate with the word suicide, right? Which I understand we don't typically associate with terminal illness, assisted death, etc. So I would draw that distinction. And then with regard to it being a terminal illness, I actually think that I was intentionally trying to blur that because this, I don't think it's actually that cut and dry in the way this will unfold in society. I think that the way that, you know, again, if we draw a real narrow category that is terminal illness, will die soon, has the capacity to consent, all of these things, then I think that's one picture. Although even then, I think that the sort of noxious effects of low self-worth, I don't want to be a burden, all of that come into play pretty powerfully. I mean, again, even in my life and my family, like I certainly have felt those things. I imagine all of us have. And so I think both that those conditions may not be enough, and second, and also that I don't think it stops there very easily, because there are too many complex cases, too many edge cases, and frankly, well, no, I won't say it that way. There's just too much complexity. I don't think we can put this in a box and expect it to stay there.
All right. Hands for our speaker. That the speaker is thanked. Moving to a speech in the affirmative, I have Robin. Robin, are you ready to make a speech? You have up to 4 minutes.
Yeah, I want to touch on what a previous questioner mentioned, and that's agency. I have not heard a convincing argument so far tonight that the person who is affected, the person who is dying, should not have the agency to decide whether it's important to not be a burden, whether it's an act of love to spare your family, or whether that's not familial, whether life is always better than death. What I'm hearing from the people who have a lot of concerns about this is that they want to substitute their own judgment for the judgment of the person who's dying. And I just don't see how that's justified. It's ironic, I think, because some of the people who have the greatest fears, and we had previous speakers speaking to this, about this being a slippery slope and society as a whole putting pressure on people who are differently abled, for example, to not be a burden. So the concern there is that other people are substituting their judgment for the person who would be affected. And yet, when we're saying that we know better than the person who is dying, we know that being a burden doesn't matter. We know that the family would want to take care of them. We know that the person would want to be remembered in a certain way. We know that dignity is defined in a certain way. We are substituting our own judgment for the judgment of the dying person.
Thank you. Hands for our speaker. And question. I recognize April to ask a question.
Thank you, Madam Chair. So I'm going to draw a hypothetical to challenge the speaker's central claim, which is, I think, a very bold one. let's take a sympathetic case. You have a teenager who is depressed and probably life will get better for them. There's reason to believe, especially because frankly, if somebody's only 16, there's good reason usually to believe that life's going to get better for them. We have a teenager standing on a roof who says, I'm going to jump off that. Do we stop them? And if so, are we saying my judgment is more important than yours? And if so, why is that okay in that circumstance?
I think in that case, it's relatively easy because the person is a child. And in a whole bunch of ways, society says your judgment doesn't really count if you're under 18. A tougher case would be, suppose the person turned 18 yesterday and if I had to, I would come down on making sure they had thought through it, making sure they had resources for any kind of support they might need, that they had exhausted other options. But when all is said and done, as adults, I think we have the right to decide to go on our own terms.
All right, hands for our speaker. With that, the speaker is thanked. All right. So I am looking at my list of speakers behind the scenes. I really appreciate the debate staff that are keeping us organized. I have Dawn Krause to speak in the negative. Dawn, you have up to 4 minutes.
Thank you, Madam Speaker. You know, this is such a complex issue, and I really appreciate the other speakers who've spoken up in the negative on this, because it had seemed so one-sided to me, and so I thought I would share some thoughts in the negative. I have had personal experience, and I think probably every person here may have, with both people who suffer from mental illness, and also I have a father who you know, had a very long and terrible period of dementia. And so the question being, can we are we able to die on our own terms, seems to be a very black and white question. But I think it's clear from some of the responses that I've heard. Number one, you know, we don't think children should be able to make that decision. Number two, there may be people who don't have the capability of expressing what their decision would be. And so I'm struggling with this, but I'm positing the notion that do we have a duty to each other? Do we have an understanding of what it means, what a death, an avoidable death, let's say, means to the people around us? And to what extent does that duty counterbalance our absolute right to our own bodily autonomy? So I will leave it there.
Okay, thank you. Hands for our speaker. Are there any questions? Okay, April.
I always have a question, but you can you can skip past if you wish, Madam Chair. I'm curious what the speaker thinks our society teaches older people about their duty to the younger generation, and whether that teaching pushes them in the right direction. What are good things about it and bad things about it? The underneath question is, does it teach them not to be a burden and therefore push them in a direction that might not be good?
Well, I would certainly, first of all, say, April, I'm very impressed with your presentation. I do think that there is a tremendous amount of ageism in this country and in possibly a lot of Western civilization. When you get down to it, I don't think you can discount the issue of whether an individual who is old, but who is understanding that they may be moving into dementia, how they feel about what is going to be left of them, what their children will remember as the last part of their lives, what's the last thing that they would remember. And so I don't think you can discount the issue of, it seems kind of clinical to talk about, well, you know, people shouldn't be coerced or persuaded to end their lives simply because they might be a burden to their children. I think that's very, very important. You can't dismiss that, because that would be very painful to know that what you're doing to your children. So I have to agree with you that there is ageism, and that value of older people, older people are undervalued.
Yeah, thank you for that. Natalie, you have a question?
Thank you, Madam Chair. The previous speaker spoke about what avoidable death means to those around us. And I just wanted to ask, it's my understanding that to people who are suicidal, death doesn't often feel avoidable. It feels like a unavoidable reality, you know, the only option, right? And so I'm just wondering how the speaker differentiates between what is unavoidable and how we can kind of draw that line.
So that would be to me.
Yes.
So yeah, this is an incredibly complex issue that it has an answer in almost the billions, because every person has a different situation. But having been deeply involved with questions of mental illness, this has to be taken into consideration, that is the person who wants to end their life, who is not looking at a very, you know, short time frame, are they in fact in their right mind? That is a question, and it's sort of a very, very difficult question to answer. It's almost like the flip side of, well, you know, someone commits a heinous murder. Well, because they weren't in their right mind. Well, you'd have to be crazy to do something so terrible, but that doesn't mean that we don't punish you. It's not I guess I'm making a very bad metaphor here, but simply put, do people who are suffering from a mental illness and are in an acute depressive state, are they capable of making this decision for themselves? Are they dying on their own terms, or are they simply not capable? That's a question I don't have an answer for.
Yeah. Okay, I'm gonna say hands, thanks for our speaker. The speaker's thanked. And now just to let you know where we're at, we've got about 15 minutes more of speeches and questions. And then our wrap up is going to be about what did you enjoy and what did you learn? And that will be a time that we're going to really pull out some of those things that we've learned. So I have 9 people lined up interested in speaking on the affirmative and none on the negative at this moment. So the next person I'd like to hear from is Craig Holland. Craig, would you like to make a speech? You have up to 4 minutes.
Thank you, Madam Speaker. And just a way of introducing myself, both professionally and personally, I'm also a physician. It's interesting that the 3 physicians who spoke here are all in the affirmative, which is a little bit surprising. I think that some people thought that physicians were neutral on this, and I don't think that that's necessarily the case. My training was in internal medicine, endocrinology, and then I added geriatrics and psychiatry, and I did medical bioethics. So I feel very qualified to talk about this from a professional point of view. And personally, the worst thing that ever happened in my life was when I diagnosed my sister-in-law with early onset Alzheimer's at age 53, and she died when she was 60. So I had I was forced to experience a patient demise, a death that it wasn't an abstraction, it was very visceral. I would just make a couple comments in not any particular rational order, but first of all, physicians, there's a lot of literature out there about how they overestimate a person's longevity. They don't have a good understanding of the trajectory of disease, and they're reluctant to make a prognosis. I would go back to what Dr. Carroll talked about and the importance of semantics, because the last couple of discussions have gotten into this idea and have sort of overused the word suicide. And as a board certified psychiatrist, a distinguished fellow of the American Academy of Psychiatry, I can tell you that this is not suicide. I would ask the audience to read a book called Stay by Jennifer Heck, who's a poet in New York City, and she talks about the secular reasons to stay alive, and she makes a clear distinction that suicide is out of despair, and what we're talking about here, medical aid in dying, is a choice by a competent individual, and we've talked about the guardrails on that over and over again. So that's an important book to think about. And she also, in that book, it would speak to some of Don's concerns about a duty to your other citizens, and that's a valid concept. But I think that Robin really kind of summarized the whole essence of, I think, what we're talking about is how do we substitute our judgment for someone else's, and that's a dangerous path to be on. We don't want to force people to suffer needlessly. And not have this option to sort of take care of themselves. And in medical bioethics, autonomy is a core feature that is the first tier of everything that we sort of decide. And so I'm just speaking on behalf of the autonomy. I would also add, I wanted to kind of address what Marcia Hofer said and how they went to Switzerland. And probably most of the people in this meeting are familiar with the book In Love by Amy Bloom. And she really describes her experience going to Zurich and doing the same thing with her husband, who had early onset dementia and had to make that choice and end his life on his own terms. And what he said was, Brian Amici, what he said was, I wanted to die standing on my own 2 feet and not on my knees. I think that that's important. And if we don't have these options, then people, they take matters into their own hands. Marshall Engel was the editor of the New England Journal of Medicine. Her father had terminal prostate cancer, couldn't get the care that he needed from the healthcare system, and he committed suicide with a weapon. So I think that that's all I really want to say.
Okay, thank you. I'm going to take a question from someone whose voice I haven't heard yet. Joe Pratt, would you like to unmute and ask your question?
Madam Chair, I want to ask a question since we have a physician again. My question is related to the explosion in medical technology in recent decades, but also the extreme expense of medical technology, and especially end of life expenses, which I've read, if you took end of life care out of American medical expenses, we'd be pretty comparable to European countries as far as cost per person. But anyway, does the speaker think that cost is influencing this issue in either direction?
Okay, go ahead.
I would hope not. I don't, and I think in my understanding and my concept of medical bioethics is that the cost of care is way down. It's after autonomy, it's after surrogate decision making, it's after what's medically appropriate. And so in my career, I never really thought about cost. Now I'm probably being a little bit naive, and I think Americans never like to use the R word for rationing. The reality is that it gets rationed anyway, and especially in our healthcare system, which is different than the rest of the affluent world. There's a lot of people that don't get good health care simply because they're poor. And it's sort of interesting too, because most people that do medical aid in dying, they're very affluent and they're very white.
Okay, we'll take one more question. How about Leah? Unmute and ask your question.
Thank you so much, Madam Chair. What I wanted to ask is that I appreciated the speaker kind of narrating the thought process of, I'd rather die on my feet than live on my knees. I just feel like the app and the neg are both kind of painting the same picture and disagreeing about what it looks like. Because I feel like the gentleman, I agree, that's the feeling people have. Does he think that engenders contempt for people who seem to be living on their knees? People with severe disabilities, people who endure some of the same privations that lead people to seek assisted suicide or medical aid in dying. How often can we say my life isn't worth living when I don't have these things without implying other people's lives are also, as it has sometimes been said, life unworthy of life?
So that statement was from Brian Amici, who was Amy Bloom's husband. It's his statement, it's not my statement. And I think it's kind of a mischaracterization to say that that's a metaphor that we can generalize to this whole process.
All right, with that, the speaker is thanked. Okay. All right, we have time for just a couple more. How about for a nuanced perspective from Leslie Lopedo? Leslie, would you like to speak?
Yeah, I want to just first thank all the people who have spoken, especially the people who shared these incredibly powerful personal stories. And I greatly appreciate your willingness to do that. And I sorrow for your suffering, the suffering that you have experienced. To me, this is an enormously complex subject. And like some of the other, I'm also a physician. I'm a psychiatrist now, retired, and I was the chair of a hospital ethics committee for over 10 years. And so I've been through I've seen this in a lot of its iterations. You know, people whose families wanted them to stay alive when the person wanted to be allowed to go. People who wanted to stay alive when their families thought they should be allowed to go, or their doctors thought they needed to stop treatment. And I've experienced it personally in my own mother's passing, who, you know, when she had metastatic cancer and really was on her last legs, and the hospice worker said to her, well, you know, do you want to be DNR? And she said, oh yeah. She said, I'm not. She said, no, I'm not ready for that. And, you know, my thought was, well, when would you be ready for that? And, you know, that was her perspective. I think that there are extreme cases about which there's less argument, except for some people who have religious exceptions. I think that most people feel that people with acute depression, and I as a psychiatrist feel that people with an acute depression should not have a wish to suicide be honored. The frequency with which people change their minds as their condition changes is enormous, and you don't want to make a permanent decision based on a temporary condition. I think for people who are at extremis, like Lee Allen's mother, at the very end of her life, suffering multiple disabilities and competent to make a choice, I think many, if not most people, would say that she had the right to make that choice. And Lee, I express my sympathies to you about your loss. But I think there's a wide range of people in the middle ground. And I think there are people with terminal conditions, people with degenerative conditions that are only going to progress. And as someone, I think maybe it was Marcia said, you have a very short window, even with a terminal condition, because you have to be competent enough to have capacity to make the decision that you want assistance in dying, and you have to be able, at least in California, to administer it to yourself. So that can be, for many people, even with cancers, a very short window that sometimes pushes people to obtain the medication earlier than they might otherwise, because they want to have the options. I support people both with terminal or progressive degenerative conditions being able to make that choice at whatever point feels right to them. For people with chronic severe mental illness, that's a real difficult one for me. I think if their illness, their depression, for instance, has not responded to maximal treatment, they are suffering as much or more than someone who has a strictly physical illness. And it's hard for me to rationalize why I discount that suffering as something that they should not be allowed to end. Yet that is how I feel about it emotionally and professionally. But the other thing that I want to address is this issue of burden. And I think the burden of terminal illness can be financial and it can be emotional. And it can be just the physical pain. And it can be that for both sides of the equation, for both the patient and for their family. Is it wrong for someone in our society to wish to ensure that they can leave some inheritance for their spouse and their children by dying sooner? Is it wrong for someone to recognize the trauma and the suffering and exhaustion of their loved one from caregiving and want to relieve that burden? I think that can be love on both sides. The problem is that American society doesn't care for people who are dying. We don't care for people by providing them with adequate medical care, where they are not going to have to guarantee that they are not going to have to bankrupt themselves because they require ongoing treatments or their treatments are so expensive or not covered. We don't provide caregiving. We provide hospice, but that is not day-to-day caregiving. We don't provide caregiving so that loved ones can spend those moments with their family members in as positive a way as possible without being exhausted. That's my sort of but. It's like I hate the concept of allowing people to choose death because we won't help them.
Right.
We won't take care of them. And we don't really support people. We don't support a family and a patient in having these conversations with each other. The resources to provide those conversations are minimal.
Yeah.
So, I think I would stop there. I do support the circumstances that I described, being able for people to make the choice for themselves. But I think that we as a society could be doing a hell of a lot more.
Thank you so much. I'm going to take just one question and then I'm going to ask Sandy to speak to advanced directives. So Tom, you had your hand up. Tom, you can unmute and ask your question.
Yeah. I'm sitting here with my son, actually. Can you hear me?
Yes.
Okay. Madam Speaker, for the doctor, as I expressed in my offer that I shared, if she looking down the road, I just read an article while we were talking that right now in Netherlands, 1 in 20 deaths is euthanasia or assisted suicide. And 1% of that is people with mental health issues, probably in the vein of what she was talking about, where it's not being affected by medicine. And I would just ask her, it's just so interesting, all the doctors are on the affirmative, where she thinks, looking in the future, does she really trust our society to not let this continue to expand beyond terminal illness?
Okay, good question. And Leslie, I'm going to hold you to a minute for your answer.
Okay, I'll try to talk fast. First off, I'm not sure I trust our society to do much of anything these days. I do think, and I also want to make clear that there's a complete difference between euthanasia and medical aid in dying. Okay, euthanasia is somebody else deciding that it's time for you to die and doing that to you. And I think there are countries perhaps where that has become more of a concern. I would not support that in the United States. I would never support it. Do I think there's a potential slippery slope? Maybe, but I don't think it's likely. You know, I think for the situation of your son, for instance, he is somebody who you will need to find someone who can protect him and protect his interests when you are gone. You know, that's in the same way that people can write an advance directive and try to protect their own interests, which your son unfortunately is not able to do. So I'm not sure, Tom, if that addresses your question.
Thank you. Thank you. So I'm going to, since we're getting really close to the time that we promised we would end, I'm going to ask Sandy to speak just briefly. If you can give us your, just that thing about the advance directive, if you can just give us a moment or two about that. Sandy, would you be willing? If Sandy is still here.
Yeah, I am.
Great.
I don't mind unmute.
Go ahead.
Advance directives are really important. This, an advance directive, you spell out what kind of care, medical care you want towards the end of your life. This way, you can decide if you want a feeding tube. There's all kinds of things you can put on it. It gives you the right to decide. It stops your family from arguing with each other if they have a different viewpoint than you do. A lot of times when you get to the point where end of life, medical, there are doctors that will say, well, we can do this or we can do that. It's not making you healthier. It's not curing you. It's just prolonging. The other thing is you need to pick a power of attorney healthcare person who backs up what your beliefs are. A lot of times if you pick a family member, they're too emotionally involved. My grandma had a DNR and went in the hospital, and my aunt and my mom both, my grandma said, DNR, and they put her on a ventilator. And then she was on there for like a month and a half. I wanted to make sure that doesn't happen to me. These are things you should start, everybody should do, I feel, from the time you're 18 and on, and you review them as years go on.
Thank you.
My mom did an advance directive, all this stuff, did a pulse. And because she had Alzheimer's, it didn't count, even though she had spelled it out before she was diagnosed with Alzheimer's. That's a thing that I wish we would change. But it's up to you to do your advance directive and point out what you want and what you don't want.
Thank you very much. Hands for our speaker. Speakers thanked.